Chaitra Jayadev from Narayan Netralaya, heading retina services there. She will tell her experience, her center's experience with this potent anti-VEGF.
Good
Yes.
afternoon, everyone. Till my slides are pulled up, I just thought I will just add on what was already discussed so far. I think we've all had some experience with the previous molecules, and somehow I think the thing that we were lacking was durability of the molecule. By durability, I mean how long we can extend the duration between the injections. So with this, I would like to actually show what has been our personal experience and also our single center experience. Before that, I'll give a brief introduction about the molecule itself. I will try to skip slides that have already been presented so far by the previous two speakers. We do have an unmet need in neovascular AMD. We have an aging population, much higher than what used to happen in a decade or two before because of better healthcare. So let's look at what are the unmet needs. There are three different perspectives, one from the patient point of view, which I think we need to be extremely sensitive about. Of course, our perspective, the challenges that we face are also extremely important because we need to allay their fears, at the same time make sure that they get enough or adequate treatment. And then the healthcare perspective, which is more logistic, costing, access to healthcare, etc. So let's look at the patient's perspective. We know that it can cause severe and irreversible vision loss, and most often we see patients who are coming to us who are just one-eyed because they've not even realized that they've lost vision in the other eye. And since it affects the aging population over 65 years of age, their safety becomes a big concern because they are prone to more accidents. So we need to be a little cautious about how we treat these patients. More than 90% of AMD associated blindness, at least in our part of the country, is neovascular AMD. In the West, we do see dry AMD. And in the developed countries, therefore, it's the #1 cause of blindness. And it's estimated there are about going to be around 288 million AMD patients by 2040. So this is the projected number across the different zones. Once these patients are diagnosed to have, they don't really come in regularly for a follow-up because of multiple reasons. One is, of course, the difficulty in traveling. Most of them have to depend on someone because of their decreased vision and their age. Next, they need to be ready to give us a commitment in time, not only for travel to the hospital, but also the various tests that are done. And if they undergo the injection the same day, then we need to do the procedure. So that takes time, and it's not only for the patient, but somebody who's also accompanying them. And finally, the frequent visits. So I think these are the ones that, besides financial reasons, which do not allow the patients to come. When you look at the physician's perspective, this was a study. Most of them said that the monitoring does take time, takes a lot of resources as well, and therefore doctors are also looking for a longer duration in between each injection to treat these particular patients. They also feel that the fluid resolution, I think, is not adequate enough, which makes us, keep switching between molecules. Dr. Indu also mentioned that, in a lot of her cases that she switched and the patients are doing much better. And as far as the wow effect goes for fluid resolution or resorption, it's been extremely good with brolucizumab. So retinal fluid is considered pathological, and its resolution is most important for neovascular AMD. We see different kinds of fluids here. This is the sub-RP fluid, subretinal fluid, and intraretinal fluid as well. So these are the different components, and we want resolution of all these different components of the fluid because that's gives us more stability for the disease besides even visual improvement. So retinal fluid is the leading indicator for activity through the progression. It also helps us in diagnosis, most importantly. The time to first treatment is also an important parameter. The treatment interval depends on how the fluid is resolving, and the visual outcomes, most importantly. Disease activity, definitely we base on whether there is fluid on the scans, whether there is visual acuity disturbance, and of course our clinical findings. And from the healthcare perspective, like I said, declining vision, obviously it adds to the societal burden. the drug cost, the treatment choices, the increasing prevalence like I mentioned in the beginning, monitoring needs, OCT scans, the frequent visits to the doctor, and like I said, lifespan is improving, therefore the burden of the disease as well. So, therefore, we are always on the lookout for something different, something longer benefit for our patients. And therefore, when I mentioned all these different factors, we also need to see what is the dosing regimen, whether it's been more frequent, less frequent for our different patients. This was already mentioned, there's a huge gap between clinical trials and real world evidence, and it shows that more than 70% of our patients are undertreated in the first year itself. And we already know that the initial treatment, how aggressive we are or how early we are in the treatment is extremely important. So, this was the wide gap between RCTs and real world. You see the number of injections is so much lesser in the real world studies here. So, the number of injections that are required to maintain visual acuity in the first year itself should be at least 5 or more, and more than 7.9 injections are required to improve vision from baseline of more than 15 letters in the first year of treatment. But this really does not happen in our practice, as we have seen, which is why I come to the drug that's been extremely useful in the management of neovascular AMD. It's an advanced single chain antibody fragment. We've already spoken about the different advantages that it offers us. The affinity to VEGF-A is extremely high here. It has more VEGF binding ability per volume compared to the other available molecules that we have, and it also delivers more drug per dose because of its molecular characteristics. It has high retinal exposure but low systemically, therefore it's also good in terms of systemic morbidity. The elimination is also quite rapid, and these are the salient molecular characteristics that I told you about. It is small. Preclinical studies also suggest because of the smaller size, it facilitates better retinal penetration. High ocular concentrations are available, and each 6 milligram of brolucizumab delivers 12-fold higher molar dose than the other molecules. So, now coming to the real life experience, I am going to show you a couple of specific cases. This was a treatment naive patient, a 65-year-old female who presented with 6/24 vision. Here you can see a flat PD, regular PD there with intraretinal fluid and hyperreflective dots. So, after the first injection of brolucizumab, you can see there has been good resolution of the intraretinal fluid there, and this was maintained even after the second injection. And so, this is a quick comparison between pre-treatment and post-treatment. You saw a reduced PED there, the intraretinal fluid had resolved, and the intraretinal hyperreflective material also reduced significantly, if you can see in the scans. Now, this is a patient with recurrent subretinal fluid in PCV, 69-year-old with mild decrease of vision in the left eye despite the fluid there. The vision was 6/9. You can see here, this is we had given different anti-VEGFs in Jan and Feb, and the patient was lost to follow-up due to COVID, came back in Jan 2021. You can see there is again a recurrence of fluid there, and we gave an injection. 3 months later, again the patient came back. So, with this recurrent SRF, this is when we wanted to think like, why don't we try Broly? And you can see this was on 19th, and by July 30th, since it was a new molecule, we called the patient back in 10 days to see the response, and you can see that the fluid has come down to half. That's extremely rapid response in 10 days, and this is at 6 weeks, and this is in December 21 after the second dose. The patient has maintained good vision so far. So, inconsistent follow-up in this patient with recurrent fluid with suboptimal response, and after Broly we were able to stabilize the disease. This is a persisting SRF in a patient. There is a solid PED. You can see the patient was started off with anti-VEGF 3 loading doses. The vision was 6/6 in this patient. So, we are a little skeptical, how to go about treatment when the visual acuity is good. Of course, the patient does have discomfort or metamorphopsia, but visual acuity is still 6/6 in this patient. So, this was after loading dose. You can see in Jan, Feb and March, there was the resolution. I would say the PED has also come down a little bit, but there is no complete resolution despite the loading dose. Since there was persistent SRF even after the third dose, we went ahead with brolucizumab. This is in April, and you can see by May 21, 1 month later, you can see fantastic resolution. You can see even the PED has started coming down. So this is after the first, the second, and after that the disease has been stable. We've not had to retreat this patient so far. So good response to Broly after loading dose. We always wonder whether loading helps, doesn't help. It also is dependent therefore on the molecule here, because you see that the response was not great, but after we switched, it did improve tremendously. This is a 65-year-old gentleman, blurred vision for more than 2 years, multiple anti-VEGF injections already received. Here again, the vision was fairly good. So I'm just going to show you, this is a poor response to treatment for a recurrent disease. This was post PDT and anti-VEGF. Again, vision was fairly good, and we kept following up this patient, lost for follow-up again, unfortunately due to COVID. And you can see the recurrence is quite bad. Amount of intraretinal fluid, and you can see SHREM as well. So this is when we decided, let's try Broly. You don't, expect this kind of a response, but we were quite happy. This was a poor follow-up patient with multiple injections and acute on chronic, and good response of the intraretinal fluid to brolucizumab. Unfortunately, because there was a delay in treatment, the visual acuity improvement was not, as well as we had expected to be. Now, I think the biggest concern because of a rapid drying is, will we see a rip, especially in these patients with large PDs, which is why I wanted to show you this particular case. Again, scary because it's a one-eyed patient, already lost the other eye, already received multiple injections in the left eye. So this was a patient, again, you can see even the angiography is there for this patient. This was in 2020 when the patient was receiving bevacizumab. And then we again switched the drug because there was not great response. You can see some improvement there. This was, I think we've seen the patient last on 27 Jan, and the patient comes back in a month, and you can see there's a massive increase in the PD. You can see some subretinal fluid as well. And that's when we thought, now that we have some experience with Broly, why not try it? So the patient received the injection on 27 Feb, and this is on 6th March. It's just 1 week later. You can see how nicely the PD has started collapsing. The subretinal fluid also has started getting resolved. This is in 6th March, and by 20th March, 2 weeks later, the PD is further reducing. This was post the third injection. The disease we thought was quite stable, and we've been following this patient. So this is a large TENS PD in a one-eye patient. We were a little concerned whether to go ahead, but then we did get extremely good response with Broly. So just last few slides on our experience here. We've used about 926 injections so far. CNVM has been the most common indication, followed by DME, and out of these 30% of the eyes have been treatment naive. Post-treatment, the visual acuity is improved, the CSFT is reduced, and there's significant resolution of the PD, subretinal fluid and intraretinal fluid. 3 eyes of them developed some IOI. And none of these patients have really lost vision when you compare it to the pre and post treatment. Despite the inflammation, most of them have, 2 of them regained vision of 6/8 and 6/6 in this patient. No cases of DME in our series had any intraocular inflammation. So to summarize, yes, chronic CNVMs, definitely Broly is indicated with fresh activity for sure. Even tough TENS PEDs, we have seen good response, persistent SRF, intraretinal fluid with hyperreflective material. We've also used it for flat and solid PEDs with recurrence and good response. Treatment naive cases, almost 30% of them. Non-response to anti-VEGF switch is definitely warranted because there's great sub-RP response penetration. We also get good resolution of PEDs. Thank you so much.
Thank you, Chaitra, for this